depending on where you're coming from. Gilbert, I think we can hear you in the background. Depending on where you are, good evening, good morning, good late night. So I'm going to tell a story today. I had a patient a couple of years, a couple of months ago. Very, very smart, very well-informed patient, and genetically very lucky. He's also a health nut. He's done really good work. He was in his late 60s, or is in his late 60s. And even up until then, had not shown significant insulin resistance, prediabetes or diabetes. And that's unusual, very, very unusual. And I used to tell him, I'm so envious of your status. And he said, well, I yes, got a lot of longevity in my family, and I read a lot, and I do the right stuff. But as often happens, this year, his OGTT went south on him. In fact, he went from very little problem to almost diabetic in that 1 year period. And it was a sad day. It was very frustrating for him, frustrating for me, but that's why we do what we do. That's one of the things that we do. One of the reasons that we watch insulin sensitivity, at least on an annual basis, or clearly if you gain or lose 10 pounds, is because that's what drives the things that kill us, that maim us. Heart attack, stroke, number one cause of eye disease and blindness, number one cause of kidney failure and going on a kidney bypass machine. Lots of problems associated with it. If you've seen our channel before, that's exactly what we help people understand and deal with. And he said, again, he went through the emotions. He said, well, Doc, I've been working with you a couple of years. I am so glad, just what happened. You've earned what? All the effort we've put into this. You've earned the cost. You've earned all the time that I put into it. It is so helpful to know, because now I know some things that I need to do, and I can just continue on without sustaining all that damage that people sustain when they develop insulin resistance or even diabetes and don't know it. So, it was a sad day for him, and obviously for me too. But again, a bittersweet moment, because we also knew that, yes, that moment can and will save maybe a decade or more of his life, because now he can protect himself. Well, so then a couple of weeks later, I got an email, and you could tell he was not happy. He didn't just come out and say, Doc, you're an idiot, but he was frustrated. And he basically started sending me all these things that he had looked up. And what he had looked up was all this stuff about, you got to do carb loading before you do a GTT or an OGTT or an insulin survey. And that carb loading, we'll talk about what that means. 3 days, 150 to 200 grams of carbs prior to the OGTT or insulin survey test. And that's to theoretically get you ready. We first started hearing a lot of pushback on this about 4 or 5 years ago. And so since it was the prevailing wisdom out there that you had to carb load, we went ahead, and Michelle and I developed a series of steps and to tell people about carb loading before their test. And sure enough, about 1 every 20, and he was one of them, will not get the message. The other 19 will get the message. They'll do their carb loading. Or, gosh, I get about 2 out of 20 who say, Doc, I can't carb load. I'm addicted to carbs. If I eat carbs for 3 days like that, I'll fall off the wagon and I don't know if I'll ever get back. And so, my response to that is, well, look, we got to do, it's a very helpful test to understand just how insulin sensitive you are. But if that's going to throw you off the path, if that's going to trick you back into your addictions and take you in a bad place, then don't do it. Now, again, this is all based on the assumption. And believe it or not, the assumption goes in two different directions. And this is a classic kind of problem that I run into all day, every day in what I do. You've heard me use the term internet doc, even acknowledging the part that I'm on the internet and I talk about medicine and medical science. Unfortunately, I'm one of the few people that actually looks at the evidence. And that's what you find way, way too often. You find people talking about something that makes sense to them and spouting it as science. They don't look, and most of them aren't trained to look. Most of them don't even try to look to see, is there evidence behind my theory? And so if you've been there, most of you on this channel have studied this enough, read enough about it to where you probably already have opinion. Oh yeah, you got to do a carb load. And your opinion may go one of two different directions. One direction is, if you don't do a carb load, your pancreas will have gotten used to not using any insulin, and it's going to look like you have diabetes, but you won't, just because you surprised your pancreas. In other words, you didn't carb load, you were on a low carb diet. Your pancreas was looking the other way because it's just been resting. And then you hit it with a glucose tolerance test, and all of a sudden it's not ready. So you get artificial diabetes. And that's what this patient thought. He was so upset after going through the emotional moment that he went through, realizing that he had gotten diabetic, not overnight, but over a year's period when he'd never had that problem. And he was continuing to manage his lifestyle. And then to find out, oh no, he really didn't get diabetic. That was a false test because he didn't get the instructions from us. He didn't do a carb load. And so that was false diabetes. That was his perspective. And then he started sending me these articles. To be totally transparent on my side, I had not dug into the science on this before. I just said, okay, you know what? I'm getting so many people saying you have to do a carb load. I'll just give them the instructions, the information, and then we won't have to deal with that pushback. Now, it was interesting. So he's most of the citations he sent me were people spouting their opinions with not a real study. But one of them was a real study, and it was done back in 1960. And he said, yeah, here's another one. It's a real study. He said, I don't have a subscription to the New England Journal. But here's the thing. And again, it proves that you got to do you got to do carb loading for the few days before you take this test, or it will show that you have false diabetes. Again, there are some out there who would say, it gives you a chance. It shows a false negative diabetes. And for those of you who have a question, what could be the mechanism for that? I'll describe that. Ask the question back in the Q&A section. I'll describe that. But here you've got people spouting their opinions based on really good logic, but not on the evidence, not on the science. So he didn't have a New England Journal subscription, but I do. I looked it up, and today we're going to talk about this randomized clinical trial where they actually tried this. They took a group and did carb loading, and a group and didn't do carb loading. And they already knew the diagnoses for these folks before they did the study. We'll see how big of a deal this really is. So, but before we do, though, let's talk a little bit more about this channel. So why all this focus on insulin resistance diabetes? Because it is the underlying root cause for, like we said, blindness, heart attack, stroke, heart failure, kidney disease. It's the thing that's really killing and disabling more of us than any one other thing. I mean, if there was an article that came out recently looking at the death rates, so comparing over the past 2 years, 3 years, COVID versus heart attack. There were 1 or 2 spikes where COVID actually beat out heart attack. But during the vast majority of the past 2 years, more people were dying from heart attack than COVID. So again, this is killing more people than anything else. It's also the #1 cause of stroke. So it's more people that are disabled permanently than anything else. And guess what? The other thing I'll tell you about this is most people depend on their doctor to tell you about it. And guess what? The science is also really clear. 2/3 of doctors don't know how to diagnose this problem, let alone manage it. So people then think, well, you know what? You can just, once you get into your 60s or 70s, you're going to have a heart attack and it can't be predicted. And if you don't believe that, just go ask your doctor. That's what the doctor will say. So I'm trained in preventive medicine. I used to teach preventive medicine at Hopkins. I ran the program there, training other doctors. So I know prevention. I touch on other aspects of prevention, but I really focus on this because this one item, again, is killing more people, disabling more people than anything else. And we have a couple of ways. We deal with this in a whole bunch of different ways. We've done recent content on, are statins really causing your muscle pain? The 4th jab, was it yes or no? And we talked about Melanie's weight loss of experience. So we have a lot of content associated with learning what the root causes of your metabolism that can kill you. If you want to learn to protect yourself, you can get these 3 courses. If you say, okay, you know what, doc, I love those 3 courses. I can't afford them. Check in with Michelle. We'll see if we can get it to you for free. Our goal is not to make money other than to help spread this information to the rest of the world. And that's our goal, to get this information out. In about 6 hours, 2 hours on each course, you can learn more about insulin resistance prediabetes, plaque evaluation, and cardiovascular inflammation than your doctor knows. 90% of doctors. And if you say, oh, well, 6 hours is way too long, just get the one course, insulin resistance. That's the root cause of all of this problem. So, well, not all of it, only about 80% of it. So get that one, spend a couple of hours, protect your life. I'm not going to go into other components today of our content. Again, you can see that as you look at our channel, as you look at our website. Now, we've got so much content that we're covering. We had to start doing a quick shorty, a single slide, which talks about something about, hey, did you know this? And it's going to be in the area of prevention. And that's what this one is today. We'll cover this. Then we'll go to the, Gilbert will give us the water ball, and then we'll go into the content for today. So this one is in aromatherapy. You know, aromatherapy is not something I get too deep into. I haven't seen a whole lot of scientific evidence that it's a big deal. However, I don't argue with it. I think the purpose for aromatherapy is really more for emotional rather than anything else. So I don't have a dog in that fight. That's what we say in the deep south of the United States, where I'm from, except when it starts doing harm. And here's what happened. There were some aromatherapy products that were for sale in very large stores like Walmart, big stores where the whole US, could stop and pick this stuff up. Those aromatherapy products were killing people. So here's the story. Melioidosis. What? Don't worry about it. It's an uncommon infection caused by a bacteria. What's the name of the bacteria? If you're a geek and you really want to know, it's called Burkholderia pseudomallei. That's Burkholderia pseudomallei. So aren't you glad that I took the time to read that another technical term out? Here's what it is. It's associated with exposure to soil and water in tropical and subtropical environments. So why was that killing United States residents? Again, because these products were put into aromatherapy that was being sold in community stores for aromatherapy. 4 non-travel associated cases in Georgia, not Georgia the country, Georgia, United States, Kansas, Minnesota, and Texas were linked to an aromatherapy spray imported from an endemic area. An endemic area just means an area where there is a good bit of this bacteria in the soil of that area. They used products from plants and soil in that endemic area to make this aromatherapy spray. That spray, again, was sold in retail outlets. Melioidosis is associated with pneumonia, severe infection of the lungs, septic shock. In other words, your blood pressure just crashes because of the infection. Septic arthritis, the infection gets into your joints from your bloodstream. Osteomyelitis, it doesn't just get into your joints, it gets into the bone. Once infections like that get into bone, if you do heal it, if you do cure it, it often takes months, maybe even years of intravenous therapy to clear up osteomyelitis or bone infection. It also causes neurologic deficit, damage to the brain. 2 patients died as a result of this illness. So be careful about aromatherapy. It's I've stopped and sniffed some of those things too in a couple of these grocery stores and thought, that smells good. The rest of my family's not into that, so I never, I got a lot of pushback when I thought about using it. I'm glad I didn't. So there you go. Be careful what you do in terms of aromatherapy. So Gilbert, if you'll give us the water ball, we'll go back to the topic for today, the carb loading. So you're getting an OGTT, oral glucose tolerance test, or an insulin survey, the Kraft insulin survey, where they actually look at, well, wait a minute, what is an OGTT? It's where you get fasting glucose, blood glucose. You give somebody a challenge, usually 80, but it could be 100 grams of glucose in a little bottle of water. That's syrupy, sweet stuff. And then you get blood sugar values, usually sometimes half an hour, 1 hour, and 2 hours, sometimes just 1 and 2 hours. And the insulin survey is the same thing, except you also get an insulin test every time you get a glucose test. Why do we do that? So we can measure whether or not you can safely metabolize carbs, glucose. Why? Because, again, by the time we're 60, by the time we're 30, over half of us cannot. And if you want to check my data on that, JAMA Network, UCLA public health study for California. This is a very prevalent issue. It rots our arteries. It creates what we call cardiovascular inflammation. If you want to understand that, again, as I said, we've got some courses that are dirt cheap and free if you've got the time to take a look. So I told you that story. I told you about the patient that was very healthy up into his late 60s. We had that emotional moment because this was the year that his insulin resistance just, boom, went from minimal to almost diabetic, an emotional point. Then he starts looking it up and then he gets mad because he said, this was all just artificial. It wasn't real. And then he sent me this reference. So here, again, this is New England Journal of Medicine. The title is Diagnostic Evaluation of Oral Glucose Tolerance Tests in Non-Diabetic Subjects After Various Levels of Carbohydrate Intake. So here's the thing. It's common to instruct patients to eat a high-carb diet for 3 days, 150 to 200 carbs or even more, before an OGTT or insulin survey. Patients often struggle to consume 250, 300 grams recommended. This study was looking to determine the effect of lower levels of carbohydrate intake in OGTT in non-diabetic patients. And again, this was 60 years ago. They actually looked to see. In this study, they included 42 non-diabetic males. They received 5 test diets, 400 grams of carbohydrates, 300 grams of carbohydrates, 200 grams, and 100 grams for 3 days. After that, they were given a 100 gram, 3-hour OGTT. They also included 15 females. They received 3 test diets, 250 grams, 300 grams, and 50 grams for 3 days. And the latest, the 50 gram for 7 days. The OGTT was performed after a 100 gram carbohydrate administration. So even with all of these, even if you do the carb loading, you go 8 hours at least before the first fasting glucose and insulin test. You fast. It's fasted. That means at least 8 hours you don't take anything, even if you've been carb loading for the past 3 days. Then you get a fasting glucose. Then you take that 100 gram glucose and then you measure. On this one, they did it at 1, 2, and 3 hours after the glucose. What did they find? None of the 42 male volunteers met the criteria for diabetes. Only 1 male on the 100 grams diet met the criteria of potential diabetes. There was no statistical significance between folks. None of the 15 female volunteers met the criteria for diabetes. So, to carb load or not to carb load? False positive. So here's we're going to walk through a couple of the theories, and they go in diametrically 180-degree opposite directions. The first theory is you get false positives. In other words, if you don't carb load, your pancreas will not make and will not store any insulin. Therefore, when you do this test, it'll catch your pancreas unawares, and you'll get what's called a starvation diabetes results. In other words, it's not ready to put out any insulin. So your blood sugar goes up and stays up. As we saw, and as you'll see, nope, that's not true. False negative. If you don't carb load, you'll have an artificially high level of stored insulin, indicating less insulin resistance than reality because your pancreas will have a whole bunch of insulin. It's not used to having that because you're on a low-carb diet, and it's stored it up, and it can hammer down that glucose value, indicating you really don't, it controlled it. You don't have insulin resistance. You don't have diabetes. And therefore, false negative. The study suggested that neither of the above are true. Given the study design, the false negative couldn't be ruled out completely. So here's another one. Carbohydrate intake prior to oral glucose tolerance test. This is in a not so well-known journal. It's Journal of the Endocrine Society. 2021, I think. Yep, 2021. An OGTT was performed in a volunteer, first without adequate carb intake in the evening meal prior to the OGTT. The resultant elevated plasma glucose levels mimicked the loss of first phase insulin resistance. A second OGTT was performed with prior carbohydrate intake in the evening prior to the study, resulting in normal results. So what does all this tell us? I think one of the key things is, look, the evidence that these are false, that you're getting false readings if you don't carb load. I don't think that's true. So if you'll give us the transition, we'll go into Q&A. So let me go back. I need to make a couple of changes here to get to the Q&A. Here we go. Bart Robinson, good to hear from you, Bart. Tuned in and ready to go. Thanks. Bobby Ocampo, Mabuhay. And I think that means live long, live healthy, something like that. Bobby's in the Philippines. I just read Steinbeck's The Pearl, reminded me of the Philippines, a very poor country. A young married man with a wife and baby discovered a pearl, a giant pearl. And it didn't, he thought it was going to make his life wonderful and make him rich and afford to do some, get married, afford to christen his baby, afford to get his baby educated to learn how to read. That's not what happened. If you haven't read Steinbeck's The Pearl, it's a classic. It only takes a couple of hours. And it gives you some perspective and thoughts about the human condition. Pardon me for going down that bunny hole, but thinking about it made me think about the Philippines, part of the world where the economy is not as fortunate as a lot of the other countries, but some really, really good people, some hard workers, and some folks that are big fans of this channel. Also, a lot of folks with prediabetes because of my work with employees and consultants that live in the Philippines. A major group of folks that I've worked with in the past are from the Philippines. Diet heavily laden in carbs, rice and fruits. Rice and fruits. And when you're done with that, more rice and fruits. Had a patient who was a Filipino. He owned a Filipino restaurant in Canada. In his 30s, very, very young man, came to me at the Louisville conference, and his cardiologist and then his thoracic surgeon were saying, if you do not let us do a bypass on you now, you will die. And he did not want to bypass. He had an infant less than a year old. He and his wife were scared to death. And yes, he had some diabetes. He had significant diabetes. And guess what? He was eating 2 bowls of rice 3 times a day with a bunch of fruit because that was his restaurant. That's what they served. He cut down on he cut out the carbs. He heard this. We looked at a couple of other things, but it was mostly this. I talked to him recently, about a year ago, and he was doing fine. So again, Thank you so much, Bobby. Mabuhay to you too. ET himself, thumbs up, folks. Yes, it doesn't cost you a thing to help get this information out. If you're interested, we have patients in Australia, New Zealand, Brazil, the Middle East, Singapore, Malaysia, all over the world. So if you do thumbs up, and especially if you link this to your Facebook, Twitter, any of those social media pages, it helps get that information out to more and more people, because the algorithm looks at that and says, you know what? A human thought this was important enough information to take this over to another social media outlet. And that pulled eyeballs from that social media outlet back to YouTube. So again, please give us some thumbs up at least. And even more importantly, put us on your Twitter, your Facebook, your Instagram. Bart Robinson, hello, Bart. Bobby Ocampo, how low level of A1C in your experience that is more or less would pass insulin assay test? You know, that's an interesting question, Bobby. Here's the general sort of a golden rule. Anytime your blood sugar starts getting into the mid fives, or your A1C starts getting into the mid fives, be afraid. Be very afraid. Mine started creeping up to 5.6 at a time when, my challenge glucose started hitting 180. So now that's nowhere near the standards for doctors to worry about. The standard for diabetes is 6.5. Doctors tend to not worry until they see a 6. And when you hear a doctor say, you got a touch of sugar, be afraid, be very afraid. Again, don't say, I don't have much of a problem. Don't do what most people do. Say, well, I won't drink as many sodas as I used to, or sugary drinks. That's not what, that does it, but you need to understand much better what's going on. So the other thing I would say is be careful depending on A1C. Everybody says A1C is the way to go. It's easy. It gives you an average of the blood sugar over the past 3 months, but it's associated with hemoglobin. And guess what? The AACE, anybody want to know what that means? American Association of Clinical Endocrinologists. They're very clear. I put it in a couple of my slides. I've got 1,000 videos out there. So you probably, you may have seen it, but you probably haven't. But the AACE says this is an error. It's a big mistake to make this diagnosis based on A1C. Now, why do they say that? It's because of hemoglobin. And anything with hemoglobin can change these results. I've had people with sickle disease. I've had people with sickle trait. I've had people with thalassemia. I've had people with kidney disease, liver disease, pregnancy. All of these things change your hemoglobin dramatically. So that's why the AACE says don't depend on A1C to make your diagnosis. I'll tell you something that I see with my patients, which is even far more common. If somebody comes to you, or if you're on a low carb diet, your your A1C is going to be low because you're never getting your blood sugars up there. I've got plenty of people with A1Cs in the area of 5, even lower, that have full-blown diabetes. Let me repeat that. I've got a lot of people with an A1C 5 or even lower that have full-blown diabetes. Now, why is that? Because they're just not eating carbs. They're taking the risk off the table. So again, please be careful about depending on A1C. Bobby Ocampo, Dr. Richard Bernstein's using 83 and below as the normal fasting blood sugar. I have every respect for Dr. Richard Bernstein. He lives close to where I used to live in New York. And he is the godfather of diabetes self-care. He was an engineer originally and had full-blown diabetes. His wife was an ER doc. She brought this gizmo home, big item, back when he was like in his 20s or 30s. And the reason she brought it home was that was a machine that had been built for ER doctors like her to measure blood sugar of people coming in. You know, if somebody comes in and they're comatose, their blood sugar might be really, really low, or it could even be really, really high, several hundred. Because her husband was a brittle diabetic, she said, I would like to, try this on Richard. So he took off with that. His engineering mind got very interested in it. He started doing studies. He started submitting these studies to the medical journals of the day, but they said, well, what do you know about this? You may have diabetes, but you're just an engineer. You're not a doctor. So he continued to get more and more interested. He went to medical school. And again, he has since become the father of diabetes self-care. And if you think, well, self-care is not a big deal. Self-care is hundreds of times more important than anything a doctor can do for you. So you can take the risk of diabetes essentially off the table with self-care. Dr. Bernstein in his 80s had HDL values up approaching 100. And that's just incredibly unusual in somebody who doesn't have diabetes in their 60s and 70s, let alone somebody in his 80s who's had full-blown diabetes his whole life. All kinds of respect for Richard Bernstein. Independent of my respect for Dr. Bernstein, I agree. 83 is a great number for a fasting blood sugar. Any experience in A1C below 5 and still fails the insulin assay test? It was a great question. I should have waited to say what I said a few minutes ago, but I have tons of patients. Now, in terms of reality, I'd say it's less than 1 in 10 full-blown diabetics with A1Cs below 5. But I have a lot of them, Bobby. And again, it's because they do their exercise, they keep their body fat low, and they don't eat carbs. Forked tongues kill. You go to the root. Thank you. Well, thank you, Forked Tongues. I appreciate that. Peter Grant worked with a guy called Cheesesteak. Oh, that's interesting. Ordered one every night for his dinner, Mr. Cheesecake. He died at the age of 55 of a massive heart attack. He wasn't looking for longevity, but the enjoyment. Yeah. We're going to do a video, and we just put it in the queue last night. We started seeing for the very first time some information which shows by indicator, by A1C, by LDL, by fasting glucose, different metabolic indicators. If you can control them like Dr. Bernstein did, and like he teaches others to do, what kind of impact does it have on your life? I consistently say to patients when they come in to see me, and I'll see plaque, but I don't see much on the OGTT. And it's like, did you lose like a lot of weight? And the answer is, oh yeah, I lost 30 pounds. I lost 50 pounds. One of them, yeah, I lost 150 pounds. So why would I ask that? Well, because if they've had plaque, it's probably because they've had diabetes and they've burned their arteries with the diabetes. And it was probably due to the body fat, because, we used to think the body fat was an inert energy storage tissue. That's not what it is. It is an endocrine tissue, and it causes this problem. Now, let me, anytime you say that, a lot of people think, well, there's a diabetes epidemic and there's an obesity epidemic, and the obesity epidemic is causing the diabetes epidemic. Yes and no. It clearly does cause that problem. But guess what the number one cause of the diabetes epidemic is? It's aging. It's not obesity. But obesity is a very important number two. And why is it so important? Well, you can't really do anything about age, or maybe you don't want to, but you can do something about body fat. Consider it, think about it, and there you go. Now, one of the things, I'll go ahead and do a spoiler on that study that we're going to be presenting. So I'll typically say to a patient, well, you've probably gained, you've probably saved a couple of decades of life. And they'll say, just by losing that 40 pounds. And I'll say, yeah, because we know you're pre-diabetic or even diabetic when you had that weight, because look at all the plaque you've got now. But that plaque is stable. We look at all of your metabolic indicators, and they're good at this point. So you were going down metabolically, you were headed to an early death. Now you've reversed it. You've stopped that. But obviously you can't fall off the wagon. If you do, we know metabolically where you're going to go. This old plaque in your arteries is clear proof that if you fall off the wagon, you'll die. You'll die early, or at least you'll be at risk for it. And pardon me if you think, well, doctor, you should have better bedside manner, or in this case, webside manner. It's reality. You need to be aware of it. So you go looking at this study that came out, and it's like, 3 to 5 years for managing blood pressure, another 3 to 5 years for managing A1C, another 3 to 5 years for managing HDL. And you think, well, maybe you're not really helping that much. Number one, it's a little bit deeper story than that. And number two, do you really want to take that chance? I don't. So thank you, Peter. It was a great comment, and it gave me a chance to create a spoiler for some very important upcoming information. ET himself, years ago, I had an ultrasound on my ankle, and neither could the cardiologist or my GP simply not explain the results. What were they looking for? If I can find this out, I can figure it out. Well, I don't know. I'm sorry, but I don't know why they did an ultrasound of your ankle. You obviously were having some sort of symptoms with your ankle, and maybe they were looking for something. Maybe, you can pick up things like tumors with an ultrasound. You can also pick up, tumors within bone, tumors outside of the bone, cysts, what we call loculated, or cysts that have a bunch of little things in them. But I'd really need to know more than that, ET, before I would, make any comments about it. Becky Quick, is A1C of 5.5 good or headed towards diabetes? Headed towards diabetes. As I said earlier, once you get into the mid fives, you really need to be careful, and you need to have a much deeper analysis. You need to do an OGTT, or better yet, a full-blown insulin survey. I had a 30-something-year-old, it was day before yesterday. It's a friend of a coworker. I called her, she had asked about it. She'd heard some conversations that I was having. She went to our Alabama clinics, and the Alabama clinic nurse practitioner ordered an insulin survey. And I was so glad she did, because on the fasting was fine. It was in the low 90s. The 1 hour peak was not bad. It wasn't great for a 30-year-old. It was like 136, 138, but it wasn't bad. And then the 2 hour was less than 100. So you look at the OGTT and it looks, well, you got a little bit, be careful, start watching this for the future, but you're okay right now. Except the Alabama practitioner, the Jubilee practitioner, did get insulin. Insulin started off at over 10, which is a red flag. Insulin should be 5 or less, fasting or basal insulin. Then it went almost to 200 at the 1 hour peak. So this person's blood sugar was 136, which is high peak for a 30-year-old. But the optimum insulin value to control your blood sugar should not go over 50. Hers went almost to 200. So I called her. She and I are going to be doing some work together. So I hope, Becky, quick, that gave you a good example of the things you need to be thinking about. I don't know how old you are. That's a good, that's part of the question, but you really need to get some definitive testing. Again, mine was 5.6 when I first started demonstrating very significant prediabetes. Fort Worth West Side. Hi, Fort. Thanks to you, I learned I had heart disease, hard plaque. Well, I'm sorry that you've got it, and I'm sorry to be the blame, but I'm also very glad, and I'm sure you are too, as you look back, that you know. It's so much better to know that you've got Jack the Ripper over your shoulder than to be walking along pleasantly thinking there are no problems in my life. So after doing the CA calcium score and the CIMT, intermediate test, to look at the plaque, which my cardio doc poo-pooed, told to take 40 milligrams statin, eat low fat, stress itself. Glad I dumped him. I am too. You got to fire a doc, or if a doc won't be educated, you got to take things into your own hands. And that's, again, what this channel is about, to give you the information that you need to protect yourself, because most doctors won't. I'm sorry about that. That's not me saying that. That's the science. That's the evidence. Some of my old cohort back at Hopkins or started these studies. Now docs at Mayo, Harvard, other places have all done similar studies to where they look just how much does a cardiologist, an internist, a family practitioner, this is here in the US, how much do they really know about prediabetes? How much do they know about how to test for it, diagnose it, how to manage it? It's abysmal. So you're not protected by your doctor. You got to learn stuff. Fort Worth, what causes the delayed 2 or 3 hour insulin response on a Kraft test? The delayed response is very common. It's the most common first thing you'll see. You'll see loss of what we call the first phase. You see, the first phase, the pancreas actually even stores insulin. And so if it's not using insulin, if you're doing well, it builds up a certain amount of insulin, and it's just got it right there on standby in case you eat something that it need, or your blood sugar goes up and it needs to lower it. Once you start having problems where your insulin receptors start pushing back against that insulin, typically what will happen is your fasting insulin will go up. You remember I described the 30-year-old a few minutes ago, and I said her fasting glucose was fine in the low 90s. We'd love to have it, as Dr. Richard Bernstein says, in the low 80s, but low 90s is not bad. But it was taking her twice the amount of insulin that it should have to decrease and to keep that fasting glucose at a normal level, at a healthy level. And so what was happening was, it's what I call running hot. Your insulin receptors, the primary problem in over 90% of diabetes is that your insulin receptors stop responding so well to insulin. So your pancreas has to put out more and more. There's a nucleus in your brain that's constantly measuring your blood sugar. If your blood sugar is getting too low, it can impact cortisol or epinephrine to have your liver put out, cleave a little glycogen and turn it into glucose to put out glucose in your blood sugar. But if it's constantly high because your insulin receptors are not responding to the insulin, then after months and months and months of that, or years, your blood sugar, it starts getting used to blood sugars in the low 90s, from the low 80s as a teenager, then the low 90s. And my typical patient will come in with fasting glucose a little over 100. And if you got a fasting glucose a little over 100, you've got insulin resistance. There's no question about it. So that's how some of that starts. Once you start requiring too much insulin to manage even your fasting glucose, then you start losing that first response because your pancreas is not able to store that insulin because it's pushing it out to manage that fasting glucose. So you start getting into a vicious cycle. It's taking more insulin. You're not able to store it. You don't have it around. So your pancreas is starting to work harder and harder and harder against those resistant insulin receptors. You lose that first phase, and then it takes longer and longer and longer for your pancreas to build up enough insulin to finally overcome that blood sugar. I hope that helped, Fort Worth. It was a great question. Thank you. Bobby Ocampo, false positive insulin resistance is far better than false negative. Yes, if I had to choose between the two, false negative is the real problem. People think I'm okay when they're not. But again, when you start looking at the science, the evidence, the reality is I'm not so sure that false negative exists either. I think I would get the tests. And that's what I advise my folks. Kurt Bryant, may I get your thoughts on L-arginine and its impact on vascular health? L-arginine, citrulline, a bunch of other related things in those categories. There's some evidence. The evidence is typical of what you see with a lot of supplements. Not vitamin D, not so much niacin, but a lot of other supplements where clearly the logic is there. Maybe a little bit of evidence to support it, and that's what you get with citrulline, arginine, those kind of things. Now, here's what the other thing that you get. You'll get some subpopulation that's really emotional about it, and the bodybuilders have this. It's like an urban myth among bodybuilders. Man, I got a huge pump because of citrulline or because of arginine. So you got to use it. You got to use it. You got to use it. To me, it's like, I don't use it. I mean, I don't think it hurts you, but I don't think it's what it's cracked up to be. Fort Worth West Side, despite the delayed responses, does it mean you're producing enough insulin volume-wise, just slow delivery? Well, I hope that when I got into detail on that process a few minutes ago, Fort Worth, that it helped you understand the details of what's going on. At the end of the day, the vast majority of diabetes is caused by failure of the insulin receptors. And that's why we call it insulin resistance. The receptors in our body are no longer responding as well to insulin. That's why we lose weight, because body fat releases chemical cytokines and some other things that tend to cause this problem. That's why we push for exercise, high intensity intervals, resistance training, because large muscle groups that are working or have worked recently bypass those insulin receptors. They just don't use them. They don't need them. They just soak up blood sugar out of the blood without having to do any insulin. So that's why we do what we do. That's why we don't eat carbs. If your insulin receptors aren't responding to insulin, you eat a lot of carbs, your blood sugar is going to go up and you're not going to have a way to deal with it. So again, I hope that answered your response. Tamara Spillis, best doctor and friend a patient could have. Love of people has made you truly a doctor without borders. Well, thank you so much. I say this because of your encouragement to contact Michelle if needed to benefit from courses. Okay, I get it. Well, thank you. And again, yep, it's we do save lives. There's no question. If you watch this channel a lot, you read the comments. People say it over and over again. Hey, doc, I got your test. I didn't have prediabetes. I had full-blown diabetes, and my doctor didn't even know. There's just so much of that out there. And guess what? Even the CDC, and for the most part, I respect a lot of good work done by the CDC, but I know they've come under fire recently. Here's the bottom line. Even they know with their challenges that over 90% of people with this problem don't know it. So we've got a lot of work to do in this space. Thank you so much, Tamara. I appreciate that. Kurt Bryant, last OGTT, 75-gram results, fasting 96. Well, we would hope for better than that, but it's not bad. 1 hour, 163. Yeah, that's where mine started getting up to when I started getting insulin resistant. You want it 120 or less. And 2 hours was 105. Yep, that's also an insulin resistance number. All three of these numbers are higher than they should be. The best numbers would be the low 80s for fasting, 120 at the 1 hour peak, and 100 or less at the 2 hour peak. Now, you say you didn't carb load before. Would these results be accurate? Yes, I think that's what, once you start looking at the real evidence, I don't think that carb loading really impacts so much. But those numbers also indicate insulin resistance. Those numbers indicate that you can, and unless you do some things in your lifestyle to control it, you can and will get to blood sugar levels well over 140. And you look at Blood Sugar 101. I think she does Jenny Rule, her book, Blood Sugar 101. It's a website, an award-winning website. She's a diabetic, and her goal is to teach people about managing diabetes and prediabetes. In her book, Blood Sugar 101, she's got a great chapter which talks about the science around at what point do you start forming plaque. And I think, nobody knows, but she did a good job. She estimated, given what she saw in the literature, is probably about 140. And I agree. I think 140, if your blood sugar's routinely getting over 140, and especially if it's staying there for an hour at a time, you're burning your arteries. So thank you for sharing that, Kurt Bryant. Tired looking for name. The name there is obvious, the labels. Thank you so much for the contribution. That $20 goes a long way. As we mentioned before, we've got a lot of folks from the Philippines. Gilbert's from the Philippines. The economy is very, very different there because we use consultants and some of these great people that work for us, Gilbert, Aspen, Sam, from the Philippines. We're able to push our dollar a lot further. It also helps those guys get good money compared to what they would get in local economy. And so that $20 US goes a long, long way towards improving the quality of our channel. Gilbert helps me almost every week co-host this program. As you'll see, I've made several comments to him already. And as you see up there, he keeps an eye on what's going on. And these reminders, the reminders always go back to what's going on. He's showing people how to do a super chat, just like Tired Looking for Name did. $20 goes a long way to helping the quality of this channel. Thank you so much, Tired. And thank you, Gilbert, for what you do. Warren Crow. I, in work with you, did not do carb load and had glucose spikes above 300 and then dropping to acceptable levels with insulin generation. You spoke of me as diabetic, not just pre-diabetic. False window? No. I mean, again, Warren, I think, I hope what you're seeing is this evidence, this theory that failure to carb load is going to cause a false diabetes or a false negative diabetes test is just wrong. And go back and look at the definitions of diabetes. Again, you don't have to wait on me or rely just on me. American Diabetes Association, they're way too conservative, but even they say anytime, any kind of test, anytime your blood sugar goes over 200, doesn't talk about carb load or no carb load or fasting or glucose tolerance test, any of that. They say yes, even with testing. Anytime it goes over 200, you're diabetic. So again, if you're significantly over 200, so you need to continue to focus on your lifestyle, the things that we talked about. And thank you so much, Warren, for sharing. Other people do need to, they see and hear a doc up here ranting and raving about stuff, but when they see somebody who actually is a patient, went through it, is learning it, it makes such a difference. Thank you so much for sharing. Becky Quick, do you wish you hadn't stayed vegan so long? And how many carbs do you strive for in a day with your heart health and diabetes? I will say that I think vegan means that you don't eat a lot of animal products. I did have, some low fat meats. I was really more focused on fats. From the time I was in Hopkins, in the 60s, 70s, 80s, till about 10 years ago. And guess what? Once I switched from low fat, mostly plant-based, to low carb, and I don't worry so much about the source. I just don't want to eat a lot of carbs. Once I did that, I was already in my late 50s, early 60s. And for the first time ever, my waist size went from the usual 33, which I'd had my whole life, to 32. And, it usually goes the opposite direction. And it's because I switched. So yes, I do wish I had switched from low fat, plant-based to low carb. Instead of waiting to age 59, 60 to do it, I wish I'd done it in my 30s or 20s. Because yes, it does make a difference. Thank you so much, Becky. That's a really good question. One True Moose, and that's truly a good name. Does the amount of heme iron in one's diet affect hemoglobin A1C? It's not so much iron and not so much iron in the diet, but I will say this: iron does affect risk for heart disease from a different perspective. Cardiovascular inflammation. People with hemochromatosis have an increased risk for heart disease, cardiovascular disease, but it's not from so much impacting A1C as it is from other issues. Keto Man. My last OGTT, 75 grams results, fasting 93, 1 hour, 250, 2 hours, 230. I did carb load prior to the OGTT. A1C is 5. Keto Man. Thank you so much. So you have demonstrated exactly what I've mentioned several times. I've got plenty of patients with A1C of 5 or below, and they're full-blown diabetic, just like you. Thank you so much for sharing that. And again, it's one thing to hear a doc say, well, I've got this patient, I got that patient. It's a very, very different thing for somebody to pop up and say, oh yeah, I'm not a doc, but I have exactly what he's talking about. Thanks again, Keto Man. And I wonder why you call yourself Keto Man. I bet you don't eat a lot of carbs, do you? Bobby Ocampo, problem is the guidelines of our endocrinologist to maintain A1C of 7. That's a major problem, and it does a lot of people a lot of damage. You are exactly right, Bobby. You know where that came from? There were a couple of studies. One was done, I used to know the names of them. They were done with, one of them I think was done with like a postal worker population. One of them was done with another population, elderly population. And what they found, they said, okay, we want to get that A1C as low as we can. And what they found was, especially in these 70 plus, especially 80-year-olds and above, they killed people with lower, pardon me, that's my dog there. She's scratching and anyhow. People with lower blood sugars, diabetics with lower blood sugars in the, I'm sorry, I think my little girl wants to appear I think she wants to say hello to the group. Her name is Ozzy, by the way, and she's a good little girl. She's getting kind of old. Now, if you go back to the studies, you go back to keep that blood A1C as low as possible, even if you're a diabetic. That's going to help you, right? And here's why doctors don't try to do that. They try to keep it up around 7. If you looked at 80-year-olds and above, 75-year-olds and above, in 2 studies, they tended to die earlier with lower blood sugars. Now, why was that? Lower A1Cs. Well, here's why. If you think about your typical diabetic on insulin, how is that diabetic and doctor trying to keep the insulin low? With more insulin. And so what was killing these people was hypoglycemic episodes. You're not going to get hypoglycemic episodes managing your diabetes from low-carb diet. That is safe. Insulin is not so safe. It can kill people. But unfortunately, to your point, Bobby, too many doctors have grown up with that overinterpretation of the studies to say, oh, it's not healthy to have a low A1C if you're a diabetic. Well, I would agree. If you're keeping your A1C low by just shoving in more and more insulin. It's going to take a long time for that myth to get out of the medical system. Thank you again, Bobby. Great point. Maddie Nikki, I've learned a lot about my heart from you. Thanks. Thank you, Maddie. I appreciate it. That's the goal. Bart Robinson. He's excellent indeed, Maddie. Thank you so much, Bart. I appreciate that. Gator. Remember, I didn't use the last 2 syllables as you requested. If you're a known diabetic, that is now lifestyle controlled. Do you still think an insulin survey is of importance of keeping track of the other metabolic markers? I do. And a lot of people will push back. I'll get a lot of folks that come see me that are full-blown diabetics, and they say, well, why do I need another diabetes test? I know I'm already diabetic. Well, you know, it's like somebody that just recently shared, what you need to know is, I mean, you can do without it. I mean, you can, people live their whole life without one of these tests, but there's a significant difference between somebody who peaks at 201 and then they're back at 1 hour and then they're back to 120 or 100 at 2 hours versus somebody else who goes to 350 at 1 hour and 250 at 2 hours. Those two are both diabetics, but they have to do a totally different way of controlling their lifestyle and their carbs, their diet, their exercise, and yes, medications as well, in order to remain healthy. So yes, I do recommend that you test every year. I do recommend that you keep an eye on just how resistant, how bad is it? Because you need to know. Can you do it without it? Of course you can. Can you get guesses from managing CGMs, continuous glucose monitor? Yes. But you need to know how insulin resistant you are. Bart Robinson, couldn't Dr. Bernstein's very high HDL be dysfunctional? Yes, it very well could, especially once you get significantly over 100. These HDLs that you see at 105 and these other numbers, quite often you got to test. You got to look at the rest of their indicators, their cardiovascular status, et cetera, to see if it's dysfunctional. His was not. Bobby Ocampo, can you still reverse a high microalbumin creatinine ratio of greater than 30? Of course you can. Doing the same, a great question, Bobby, and it's one of the key indicators of cardiovascular inflammation. If you haven't seen, if you're not aware of that, you don't know what it is, it's what really kills you. It's the smoke that comes up from your arteries. It's the burning of your arteries. And how do we test for that? We look at albumin. how much albumin you spill through the filters of your kidney. This is the microalbumin creatinine test. 30 is considered to be the limit by the labs, but for men, it's 3 to 5. For women, it's 13 to 17. Anything that high or greater, you have to start worrying about that lining. Because why is that? Well, that lining, the intima layer, is the filter membrane of each of the million filters in each kidney that you have. And so if you're spilling protein through that intima, that filter of the kidney, into your urine, guess what? It's also pretty clear that you're spilling LDL, small dense LDL, out of your bloodstream and into your artery wall where it gets stuck. That's why it's so important. And Bobby, of course, any of these things you can and we can and do reverse on a regular basis. And yes, lifestyle is at least 10 times more important than any medication. If you want to get evidence for that, that sounds like just, me voicing an opinion. No, there's evidence on that. New England Journal, about a little over 5 years ago, maybe close to 10 now, they did a very, very simple comparison, very, very simple lifestyle coaching versus metformin. The coaching was 3 times more effective than the metformin. And this was easy lifestyle. This was like walking a couple of times a week and some stuff like that. Tamara Spillis again. QQQ is fasting 12 hours for a morning draw of baseline insulin, blood sugar. Oh, question. I guess that's what that QQQ means. Baseline insulin, blood sugar, and A1C. Is that a conflict with circadian rhythm of cortisol rise and gluconeogenesis in the liver? Yeah. So, Tamara, what you are referring to is what's called the dawn effect, DAWN. And we have a circadian rhythm for cortisol. Cortisol starts to increase in almost all of us, sometime between 2 and 6 in the morning. And when cortisol starts going up, it starts pushing our liver to cleave the chains of glucose off of that glycogen and dump glucose into the bloodstream, and therefore increase your blood sugar. And about 1 in 20 folks with significant diabetes or prediabetes will start getting significant rises in their blood sugar, even though they have not eaten anything before breakfast. That it becomes a whole issue because a lot of people start saying, "Oh, I got to get rid of my dawn effect. Got to get rid of my dawn effect." I have never seen just dawn effect alone cause a blood sugar over 140. So one of the first things I tell my diabetics and pre-diabetics is calm down. Don't worry about it. Your body's not usually going to make that dangerous level. But here's the thing. People get really worried. They see a spike and they say, "Oh, this is going to cause a problem." I have had some patients with a fasting glucose of 196. That kind of level is dangerous. But the typical case, I mean, those are rare exceptions. I'll go for 5 years without seeing that. The typical case is less than 120. Once you actually get a blood sugar fasting of 120 or greater, that's also another criteria for full-blown diabetes. So you raised the question, Tamara, and as you could see, I went 2 or 3 different directions, but it's a very, very big question, and that is how to interpret fasting glucose. I know I paused for a minute because I started to head down a different path. I hope I didn't confuse the issue too much. But again, fasting glucose is a big deal, and it's significantly more complicated than you might think. Keto Man, my last OGTT, 75 grams results, fasting 98, 1 hour 250, 2 hours 230. So again, yeah, you've got diabetes. I did carb load OGTT, A1C of 5.5, keto diet. Should I get my A1C lower to 5.0? Well, if you can, yeah. I mean, the lower the better. The lower the better. Fork tongues kill. I don't take any meds. 0. Good for you, Fork. Bobby Ocampo. When I request, and I don't like meds either. I'm a doctor that doesn't like medications. Bobby Ocampo. When I requested insulin tests, I had to change doctors to recommend insulin tests with OGTT. Yep. I'm glad you did that because you're getting better information when you get that. Maddie Nikki lost 90 pounds through keto, was pre-diabetic, calcium score of 0. Well, you caught it in the nick of time. Congratulations to you. You might want to get a CIMT in addition, though, because we're going to be presenting some information in the future which shows everybody always used to say, well, if you've got a calcium score of 0, you're fine. Those of us who really know this space have always worried, what if you have plaque, but it's all soft plaque? Guess what? That's a real thing. So we actually saw a study where somebody looked for that. So they had negative calcium scores, but they still had plaque. That's the concern. Now with an A1C 4.8 down from 6, congratulations. That's a big deal. After 1 year of keto, 48 years old, fat most of my life. What are the chances that I have soft plaque? Well, that's the exact question that I was just going over. And the reality is I would get a CIMT. You can call Michelle. She can help you find a group which can get you a good CIMT in your area or an area where you're traveling. Fork tongues kill. A nice animation video. Blood sugar, heart, insulin, arteries interaction would be great. It would. It would be great. I actually thought about buying some of these. There's some groups that do animations and they'll rent them out to you or they'll sell them to you. And I thought about doing that for cost is, one issue, but the bigger issue is this. They were, for the most part, inaccurate. That's the problem. I'd have to hire, Gilbert is a great artist, but I mean, it would take a whole team to develop an animated cartoon or a picture book. Yes, we do what we can. Bobby Ocampo, since I already know I'm diabetic, I requested a postprandial insulin test with a low carb meal. And my meal an hour after insulin is 30. So an hour after your meal, your insulin is 30. That's not too bad. After 2 hours, it's 20. That's not too bad either. Fasting insulin 6.5. That's not too bad. You want it 5 or less. Very helpful information. It raises questions about how do you know you're a diabetic? What were your actual numbers? Things like that. Flick T 12. I had to step away from your presentation for a few minutes. May have missed your final answer on this, but would like to know the definitive answer. Can carb load prior to craft tests or not? Oh, carb load prior. I hate to tell you this, but that's here's the reality. And too often that is the reality. It depends on how much evidence you've got before you decide this is true, this is real, this is fact. The evidence that I see indicates that it doesn't matter. I will tell people, go ahead, carb load, because if you don't, you're going to end up like this patient a few weeks ago, mad because you decided whatever result you got was wrong. But there's no evidence is not that clear that it really matters. And I'll carb load personally. Sometimes I don't carb load. My diabetes tests that came out with a peak of 160 and then 180 were not carb loaded. And I'll typically see that. I really, as a physician who does these more than, the vast majority of doctors out there, I don't see any difference either. I really don't see any evidence of a difference. I don't think carb loading is necessary. Becky Quick, do you regret being, wait a minute. How did we get, Oh, I think you just repeated it. Terry Bucheri had a OGTT of 93, 98, 99. Good. But an A12 of 5. Did you mean A1C of 5? Which is more indicative? Both of those are pretty clear. I will tell you this, Terry. It's amazing how many times we get false negative OGTTs like this just because the lab didn't know how to do them. But that together with an A1C of 5 at 0.0, I think you probably don't have problems. But again, I'm just looking at a couple of numbers here. I'd have to see you as a patient to understand a lot more detail. A1C, okay. Bobby Ocampo, what's the complete name of Gilbert? Hope to meet him. Gilbert, I have to share that with you if he wants. Per Johnson, can you have low fasting glucose and an A1C and prediabetes? Oh yeah, no question. Yes, no question. Becky Quick, 61, mild aortic stenosis. If I start low carb now, will it help my heart if I have to replace my valve later in life? Well, I'd have to see you, and then we'd have to go into a much deeper analysis of what's going on. And even then, we wouldn't know for sure. But it's sort of like saying, if I start living healthier now, will it help? Well, probably. Leo Acapulco. Good to see you again, Leo. Taking pitavastatin, 2 milligrams. Insulin went from 12.78 to 11 in a month. But triglycerides went from 99 to 114, 115. Before taking simvastatin, 20 milligrams, what's better? What else have you got? What does your fractionation on your LDL look like? What does your HDL look like? What does, there's a lot more to this than just that. Mezzanine just started Livalo 3 times a week with daily ezetimibe 8 weeks ago. Tested LDL 54, HDL 55, triglycerides 36, VLDL 10, fasting glucose 107, A1C 5.4, fasting insulin 2.4, low carb, keto, poor sleeper, insomniac. Well, you got some good numbers there. Some really good numbers. A1C you would like to have lower, and the fasting glucose you clearly would like to have lower, but some of those other numbers look pretty good. Now, a lot of people would say, you don't want to have an LDL that low. I think the jury's still out on that. Thank you so much, Mezzanine, for sharing. Bobby Ocampo, hope we will soon have CIMT in the Philippines. I hope so too. It would be very, very nice to have a lot better access to that. So this wraps us up for today. Thank you so much for your interest, and we will see you the next time around.